Hi everyone, welcome back to our fourth video of the lecture. In this video, we will cover the glucose lowering agents, which is the oral anti-diabetic drugs that used in type 2 diabetes mellitus. This is the overview of glucose lowering agents and their mechanism of action on their target organs. Total of 8 groups of glucose lowering agents can be used to treat type 2 diabetes mellitus. As you can see here, biguanides and thiazolidinediones are insulin sensitizers which increase the glucose uptake by the muscle cells, by the adipose tissue, and besides reduce the production of glucose in the liver. Thus, this drug known as insulin sensitizer due to primarily lowering the glucose level by their action on the liver, muscle, and adipose tissue. Sulfonylureas and Meglitinides are insulin secretagogues which are responsible in inducing the secretion and release of insulin by their action binding to sulfonylurea receptors. Alpha-glucosidase inhibitors act on the small intestine to reduce the absorption of the glucose. DPP-4 inhibitors inhibit the DPP-4 enzyme that degrades the GLP-1 hormones. The latest class of glucose-lowering agent that recently approved by FDA are SGLT2 inhibitors. Let's start with the most common prescribed type 2 diabetes medication, which is the biguanides metformin. Metformin is the only drug in this class has been approved by FDA. Its major action in patients with diabetes is to decrease the hepatic glucose output primarily by decreasing the gluconeogenesis, and it increases the glucose uptake by the skeletal muscle and also in the adipose tissue for glycolysis. Thus, it will reduce the glucose level in our blood system. The metformin will enter the liver cell through the organic cation transporter 1, or also known as OCT1. The presence of metformin will inhibit the mitochondrial electron complex from producing the ATP. That will cause the high level of adenosine monophosphate or AMP, which will activate the AMPK, which is the AMP-dependent protein kinase. It also will disturbing the production of glucose by inhibiting the fructose 1,6 biphosphatase, or known as FB phase. Activation of the hepatic AMPK results in the phosphorylation and inhibition of acetyl coenzyme A carboxylase, or known as ACC. This ACC is important in catalyze the rate-limiting step of lipogenesis. Thus, it will block in the fatty acid synthesis that promotes the fatty acid oxidation. In addition, activation of hepatic AMPK will decrease the expression of steroid regulatory element binding protein 1, or known as SREBP1. The decrease of the SREBP1 expression results in decreased gene expression of lipogenic enzyme, which further will contribute to decrease the triglyceride synthesis and hepatic steatosis. This event will reduce the hyperlipidemia. It's a good thing. It reduces the LDL and VLDL cholesterol. Besides that, it will increase the HDL level. However, the lipid lowering effect of this drug requires 4 to 6 weeks of the treatment. Metformin is the only oral agent that's shown to reduce the cardiovascular mortality. Thus, it can be used in combination with other oral agents as well as in the insulin therapy. But as a consequence of the metformin blockade of the gluconeogenesis, this drug may impair the hepatic metabolism of lactic acid, which will cause the lactic acidosis. Besides that, metformin also able to suppress the appetite. It will slow the intestinal absorption of sugar and increase the glucose uptake. Compliance to the metformin therapy able to reduce about 1.5% of the HbA1c. These drugs do not bind to plasma protein and excreted unchanged in the urine, means that it won't be metabolized by the liver. The half-life of the drug is about 6 to 8 hours. Usually, the practice we will given them twice daily or 3 times daily. Patients who may experience nausea, anorexia, or diarrhea are need to advise them to avoid taking the metformin together or after the meal. As I mentioned before, a consequence of metformin blockade of gluconeogenesis, as mentioned in the mechanism of action, this drug may impair the hepatic metabolism of lactic acid. In patients with renal insufficiency, the biguanide will accumulate and thereby increase the risk of lactic acidosis, and which appear to be a dose-related complication. Hence, this drug should not be prescribed to patients with renal disease, hepatic disease, hypoxia, and CHF or shock. Because of these patients are predisposed to lactic acidosis because of reduced the drug elimination or reduced the tissue oxygenation. For patients who has end-stage kidney failure are not recommended to take metformin. It is because metformin is excreted 100% through the urine. Prolonged use of metformin may cause vitamin B12 deficiency. Because of this drug can interfere with the calcium-dependent absorption of B12 intrinsic factor complex in the terminal ileum. That is why periodic screening for vitamin B12 deficiency should be considered. Metformin is recommended as first-line therapy for type 2 diabetes mellitus because metformin is an insulin-sparing agent, does not increase body weight, or do not provoke any hypoglycemia incident as compared to insulin, sulfonylureas, and meglitinides class of glucose-lowering agents. The combination with other agents are recommended if monotherapy is failed to achieve the glycemic target, such as Janumet, Glucovan, and Avandamate. The second agent is Thiazolidinediones, which are ligands of peroxisome proliferator activated receptor gamma at nuclear receptor that can be found in the adipose tissues, in the muscle cells, as well as in the liver. Pioglitazone and rosiglitazone are the only available drugs in this class. These thiazolidinediones do not promote insulin secretion from beta cells, but insulin is necessary for them to be effective. Upon activation of PPAR gamma ligand complex bind to a specific region of DNA, and thereby it will regulate the transcription of many genes involved in glucose and fatty acid metabolism, insulin signal transduction, and adipocyte differentiation. Thus, it will reduce the production of free fatty acid in adipose tissue. This drug can reduce the blood glucose and triglyceride level in the blood. However, accumulation of subcutaneous fat occurs with this agent. The most common adverse effects with thiazolidinediones are weight gain and fluid retention. In terms of weight effects, there is an increase in adiposity or largely subcutaneous with redistribution of fat from visceral deposit. Fluid retention with thiazolidinediones usually manifests as peripheral edema, which will cause onset or worsen the heart failure. These thiazolidinediones either have a beneficial or neutral effect and enterogenic lipid profile, with pioglitazone having a more beneficial effect than rosiglitazone. Toglitazone was first of these to be approved for type 2 diabetes mellitus, but has been withdrawn after a number of deaths from hepatotoxicity were reported. These drugs are not recommended to be prescribed nowadays. The baseline of the liver profile should be monitored periodically. The third and fourth glucose-lowering agents are sulfonylureas and Meglitinides. Here are the drugs that are available in the market. There are three generations of sulfonylureas which differ one and another through the half-life of the drug as been shown here. The sulfonylureas and meglitinides share the same mechanism of action. Both of these class of drugs bind to sulfonylurea 1 receptors or SUR1, which will cause the close of the ATP-sensitive potassium channel in beta cell. It will inhibit the efflux of potassium ion through the channel and result in depolarization. This depolarization will open a voltage-gated calcium channel and result in calcium influx and the release of the insulin. However, prolonged use of sulfonylurea leads to hypoglycemia due to reduction of serum glucagon level. This event occurs due to enhanced release of both insulin and somatostatin, lead to inhibition of alpha cell secretion to release the glucagon. Sulfonylurea can reduce the HbA1c level in the range of 0.5 up to 1.5%, while repaglinide managed to reduce 1% of HbA1c. Both drugs are rapidly absorbed and highly bind to plasma protein. Meglitinides metabolized in the liver by cytochrome 3 and 4, whereas the sulfonylureas by the cytochrome 3 and 4 as well as cytochrome 2C9. Glibenclamide metabolized to moderately active metabolite, which will cause high risk of hypoglycemia. The incidence of hypoglycemia may be worsened in the renal impairment, cirrhosis, as well as in the elderly patients. Glipizide, the latest generation of sulfonylureas, are among safest in sulfonylurea, which 95% metabolized to inactive form. These sulfonylureas may be used with caution due to highly bound to plasma protein. Competition for metabolizing enzyme with this group of drugs interferes with excretion of the drug and lead to hypoglycemia. Sulfonylureas can cause weight gain. It's about 1.5 to 2.5 kg. It is because of sulfonylurea will stimulate the appetite, probably via their effect on insulin secretion and hypoglycemia. Repaglinide has a very fast onset of actions, with a peak concentration and peak effect within 1 hour after ingestion, but the duration of action is only about 4 to 7 hours. Because of its rapid onset, it is indicated for use in controlling the postprandial glucose excretion. The drug should be taken just before on each meal. It less hypoglycemia than sulfonylurea because of short half-life. However, combination of this drug concomitant with gemfibrozil, which is the lipid-lowering agent, may cause severe hypoglycemia.